president for HIV/AIDS, oncology, hospice and palliative care. It's the subgroup within World Physical Therapy. And today we have the great pleasure of having Abu Sidhanee, and he's from the United Kingdom, and he's a specialist in teenage and childhood cancers. And we also have Pia Delano, and she's from Chile. And I want to welcome both of you. And Pia also works with childhood cancers, and she's done a presentation for us in the past. So this is continuation of her wonderful work. So I'm going to mute myself and I'll let Abu take it away, and then he and Pia can do this wonderful presentation. Thank you again so much.
Thank you, everybody. It's an absolute pleasure to be here. Thank you for your time today and coming to hear me and Pia. And we both hope you get a lot out of this session. So I'm just going to move on to the content today. So me and Pia are going to share. Pia's going to kick us off. She's going to start and she's going to talk about rehabilitation in childhood cancer. Then I'm going to give you a little bit of information about global perspectives in childhood cancer. And then both Pia and I are going to share some experiences from the past year. So we're going to tell you a little bit about what we learned both from Santiago in Chile and both from London, where I'm based, during the pandemic. So I'll hand over now to Pia, who will make a start about physical therapy and rehabilitation in childhood cancer. So Pia, over to you.
Thank you, Abu. Well, first of all, English is not my first language, so please try to understand what I'm trying to say to get the general idea. We want to start talking about what it means to be a child with cancer. Like why is different from being an adult with cancer? When you're an adult that gets this diagnosis, you get to decide what's going to happen to you. You get to decide if you're going to involve more people, if you're going to tell your friends, if you're going to tell your coworkers. You get a lot of more decision than when a child gets diagnosed. And when a child gets cancer, it's not only him or her that gets cancer, it's also their family that gets involved. It's also their school, their friends, and it's everybody around him or her that gets this diagnosis of cancer. Everybody gets cancer. And it has a lot of impact both in the emotional and the social support system. And it can impact what a child dreams when becoming an adult, what it dreams of doing with his or her life. So it has a little bit of more, what I like to say, like emotional impact in the society when a child gets cancer than when an adult gets cancer. Next slide, Abu, please. So a little bit of an introduction to childhood cancer. Well, there are three main types that I think every country gets them, which is leukemia, which is central nervous system tumors, and solid tumors. That's like the big three that you're going to find everywhere. And the main treatments are the chemotherapy, radiotherapy, surgery, and transplant. Next slide, Abu. So we basically get this child that's going to get, that gets this diagnosis of cancer. It's going to get a treatment that this treatment may be from 6 months to 2 years, 3 years, depending on the age he was diagnosed, on the cancer he got, on a lot of factors that influence how much and how long is this treatment going to be. And we have a child that's going to spend a lot of time in a hospital when before the diagnosis, he will not. So he gets involved in the hospital. He spends a lot of time being hospitalized. It can be 2 weeks, months even. So he starts to be a little bit isolated of his whole life. And he has to either leave school or go to school in the hospital. He has to change his educational system. And basically, we change his or her reality because of this cancer diagnosis. And that's when we as physical therapy, as rehabilitation teams, get involved in this child's life. So we go when the child and the family are in quite a bit of a shock of what this diagnosis means. Next slide, Abu. And just to get a general idea of what this treatment entails, when I talk about the child with cancer, we're talking about years. It can be years during treatment, after treatment. We got this amazing work done by the St. Jude team, which try to show what's the cumulative burden of surviving childhood cancer. And you can see, well, all the black lines are the patients of control, which were siblings, which neighbors. And you can see that in all types of cancer, the burden of surviving entails a lot of comorbidities, a lot of other situations that appear in this survivor's life and have a very big impact on this survivor's life, even years after being diagnosed. It doesn't matter what treatment they got, it still has a very big impact on this child's life, especially if you notice in the second graph, if you notice if you had a central nervous system tumor, which is most of the patients that we get as physiotherapists. Next slide, Abu. But what are these side effects and sequels that we may see as physiotherapists? We can see some developmental issues, like delays, especially when the child is very young, like before 2 years old, and it gets diagnosed. We're talking about a child that's going to be, that is supposed to be discovering the world, and it turns out that it's discovering what a hospital room looks like. And it spends a lot of time being in the hospital, being in that bed, without experimenting what it should be. So most of under 3 years old get a lot of developmental delays when they get diagnosed. We got a lot of sensory issues, which means, well, we can get difficulties in hearing, in seeing. We also get neuropathy. We can get difficulty in using our proprioceptive system. So there are a lot of sensory issues because either of the treatment or due to the long time being hospitalized and not using your body how you're supposed to be. So it's a lot of it's a big world of sensory issues that our patients can get. We can have also cardiorespiratory issues, especially with those patients that use that are on the treatment with anthracyclines and other drugs, but especially because of the long time they get hospitalized. We're talking that you need only 24 hours for being in bed to have a very big impact in your life. And these children are in bed weeks, months even. So then we ask them, can you walk 2 blocks? And of course they cannot walk 2 blocks because their respiratory and cardiorespiratory system gets a lot of gets involved and gets a lot of it's not damaged, but gets a lot of rest in this time. And we also got pain. Pain is one of the main symptoms that our patients either on treatment and after treatment get. It has been studied that almost 80% of pediatric cancer patients experience pain at least once during their treatment. So it's one of the main issues that we as physiotherapists have to treat and have to be watchful for. The nutrition, body, and composition. Once upon a time, we used to talk about the pediatric cancer patients who were underweight. Now we have seen that depending on the patient and on the treatment, it can be either underweight or overweight, which is especially on survivors. Survivors get this like this syndrome where they, after they finish treatment and they start eating more and they are not that nauseous and they're receiving a lot of medication, so they tend to go overweight while in the treatment they were underweight. So it's important to keep a watch on that, especially as physiotherapists, because we're talking about a patient that's is not getting a lot of exercise in, unless they're in a physiotherapy program. And once they get discharged from this cancer diagnosis, they tend to get a little bit more sedentary. They tend to relax a little bit, and it implies being sedentary, and it implies not doing a lot of work. And then they get sent back to physiotherapy because they push a lot of, they gain a lot of weight, and they are still tired, and they are still experiencing pain, and they are still having sensory issues and cardiorespiratory issues. So it's something to be watchful for. And there are also, functional side effects and sequels. And by functional, I mean when the patient has to learn to move or do something again, especially those who have osteosarcoma, which means they may get amputated, or they may have to relearn how to walk. The CNS tumor patients that need to learn again how to walk, how to move with their new body. So that's a very big issue for us physiotherapy. There are fitness side effects and sequels, especially the loss of strength and the loss of body mass and the loss of muscle mass while during treatment, and it may be a little bit hard for those patients to gain it after they finish their treatment. And another main issue is the cancer-related fatigue. Just as pain, there have been studies that more than 80% of patients experience cancer-related fatigue during treatment and after treatment. And even there have been adults that have experienced cancer-related fatigue even 30 years after they're diagnosed. So it's something that cancer-related fatigue is something that involves three main areas, which is the physical area, the emotional area, and the social area. So us as physiotherapy, we try to, of course, we try to cover those three areas, but it is important also to work along with a psychologist to treat the emotional area, because sometimes the patient may be in good physical health, may be good in social health, but it can still be lacking a bit on the emotional area, and the cancer-related fatigue remains. There's also the vascular necrosis. This is something that, in my experience, we have seen a lot with patients that are diagnosed around their teenage age, around, especially in those patients that are diagnosed around 13, 14 years, when they're 13, 14 years old. We're seeing a lot of vascular necrosis that happens 2-3 years after treatment. And so we have to be watchful of that, especially when the patient starts to refer a little bit of pain or awkwardness when walking, related to his hip, for example, or his arm. We have seen a lot of vascular necrosis in the hip joint, but also we have seen it in the humeral joint. So that's something to keep in mind. And the last side effect and sequel is the cognitive and emotional that may happen. This tends to get a little bit out of our physiotherapy area, but there have been studies that prove that exercise and keeping active can help, can improve the cognitive function. And it's important to notice, to mention it and to keep it in mind, because when a patient has a low cognitive or he has difficulty in the cognitive area, especially remember things, I can't, as a physiotherapist, give him exercise for that. Like, do you remember the exercise I gave you? Yeah, of course. But turns out the patient has some cognitive issues that make him unable to remember. So it's important to keep it in mind that there are cognitive and emotional issues that may interfere with our sessions as physiotherapy and what we try to do. Next slide, Abu. So what do we have to do as physiotherapy with in childhood cancer, basically, after all those side effects and sequels that we may notice and our patients may experience? Well, what we can do is we can prevent these sequels from being long-term, from having a negative impact in this patient's life. And if we can prevent them, we can rehabilitate them. And while rehabilitating them, we can optimize the functional levels of our patients so that he or she may have a long and functional life and it can participate in society, and that cancer becomes only just a chapter of the life and not something that they're reminded every day. And that involves improving the quality of life of our patients. And this is a cycle because it's not something that's just miraculously going to stop once the patient finishes or her cancer treatment. It's something that may follow them through their life, and that we can prevent. We have to prevent the negative impact that it may have. Next slide, Abu. So, well, after seeing all that, our main assessment has to be one of the first things we have to notice is about pain. As I mentioned, pain is not related to whether the patient is during treatment or after treatment. It's something that occurs through their life, and pediatric cancer patients get more. They are more. How can I say? They're more aware of when they have pain. They remember the last time they had pain or they didn't feel good was when they got diagnosed with cancer. So pain is one of the main things we have to learn either to find, we have to learn to treat, and we have to learn to control within our patients. We have to, well, we also have to look for motor skills, and for motor skills, I mean what the patient had before being diagnosed, especially in the young ones, and what the patient can do right now. For example, most 2 years old were walking and were running before being diagnosed, and they were diagnosed because they lost that motor function, and the parents got worried. And due to the long time being in the hospital, they are unable to walk, and we have to relearn everything. So it's important to know what the patient was able to do before being diagnosed and what he's doing right now, so we can aim to do that motor skill again. We have to also assess the posture of the patient, especially there are those childs that are a little bit overprotective or their catheter zone. So they tend to, I don't know if you can see me, but they tend to do this this posture of protective posture to protect their catheter and to protect themselves of the world. We're talking about that a patient has his sport for 2 years. So we're talking a child that's going to grow with this posture of a lot of flexion, a lot of protective. Arms tend to be a little bit in the chest area to protect this. So it's something important to assess. We also have to assess the sensation of proprioception because, as I mentioned before, there are treatments that may cause neuropathy, that may alter proprioception in our patients. And also being unable to experience the world as they should can also affect their sensation of proprioception. We have to assess the range of movement, especially in the ankle area, for the same issue, because being hospitalized a lot and also using some treatment options may cause this neuropathy and may cause this foot drop in patients. And we also have to assess strength. There have been studies, of course, in adults that mention that you need to be on bed rest for only 24 hours for your strength to start to go for a little bit. So we're talking about children that are going to be 2 weeks in the hospital in bed rest, and of course the strength is going to be affected to it because of it. Next slide, Abu. And there's also that there's another issue while assessing a pediatric patient, a pediatric oncology patient, is that we have to use objective measures. We are not a lot of oncology pediatric physiotherapists around the world. We're trying to find them. So one of the main issues is we have to like still prove our worth. And by doing that, we need to use objective measures. These are some of the tests that we use every day, which is, for example, the test up and go, the 6-minute walk test to assess cardiorespiratory issues, the gross motor function measure to assess neurological and developmental issues, the pediatric balance test, which is to assess balance, also as the Rumber test, another balance test. And we also use the cancer-related fatigue scale, which you can use either those or the PROMIS. And we use the PETSQL, which is to assess quality of life in pediatric patients, in pediatric oncology patients. Next slide. And this is just to keep in mind. This is the hemogram or blood values that are used in adult patients, in adult cancer patients. And one of the main issues, why we wanted to put this here is because you can see that it says no exercise, light exercise, and resistive exercise. But the no exercise column, you can see that most of our patients or pediatric patients spend a lot of time in this zone. So it means that if you go by this table, you are not going to be able to see your pediatric patients for a long time. If you really keep this table like no exercise, okay, then I'm not going to go and see them while they're hospitalized. And the first column, the patient is going to be probably hospitalized. It's not going to feel good. It's going to be a little bit tired, but that can be months when we're talking about pediatric oncology patients. So what we were talking about is that when a patient has low white blood cells, it's better to just see him in his room and keep all the precautions that are needed, so that you won't be guilty of giving him some virus or something. But you can still see the patient in the room, and you can still do exercise while being in the room. When the patient has low hemoglobin, you need to watch out, especially for cardio training and strength training. The patient is probably going to be feeling fine, but it's going to get more tired more easily. So you have to watch out for that, but that doesn't mean you won't be able to do physiotherapy. And when the patient has low platelets, you have to avoid falls. So probably you won't be able to do some balance training, or it's better if you don't do it at that moment. And you have to be watchful of strength exercise, because it may cause microruptures in the muscles, which normally wouldn't be a big issue, but while the patient has low platelets, it may be something to be more wary of. Next slide, Abu. And this is just an example of how to treat a patient. Really, it's really an example. So first, you get a patient that has leukemia. Due to the treatment protocol, it will probably get neuropathy, because the leukemia treatments, at least here, use a lot of vincristine, which tend to have this negative effect with neuropathy. So you have to either start before the neuropathy kicks in with sensory stimulation in the hands and in the foot, with different textures, with different things, and with muscle activation. So you have to keep the patient active and have a lot of concentrated exercise with the toes, with the foot, with the hands that are very specific to prevent this neuropathy. It can have functional impairments, especially cardio, loss of strength, and cancer-related fatigue. So you have to keep the patient active. It may, and if it's a young child, it may have developmental delay, which you can either use Bobath or Boita techniques, but you have to do them through playing, because we're talking about a small child that gets diagnosed, that goes to the hospital, and that loses the chance to play with the world. And you have to be able to give them that chance back. Next slide, Abu. And this is, of course, this is a general example. And when you get a patient with a CNS tumor, of course, you're going to have to do some neurological training, assessing motor skills and treating to achieve those motor skills. You may also have a patient that has spasticity in some part of his body, so you have to treat that also. And you have to train balance and in the different levels. And by levels, I mean whatever the child could do and can do right now. For example, you have to treat what's the balance while sitting, or while crawling, or while walking. So you have to treat the different levels of balance to achieve this. And of course, you have to treat gait. You have to train to either achieve a functional and safe gait, which is the main objective of our patients and their families. You have to include, even if you understand that maybe the patient is not going to be able to walk on his own, and may need a walker, or may need any other kind of help. So it has to be functional, and it has to be safe for the parents and the child to remain a little bit of what they could do before. Next slide, Abu. So this is a real patient. This is one of my patients that had a CNS tumor. He had a medulloblastoma in the posterior fossa. He was diagnosed when he was 14. He spent around a month in a coma after surgery. He lost a lot of muscle mass, a lot of strength. You can see in the first photo from the top left, that's the first time I saw him. There are a little bit of things you may notice. For example, his hands, you can see that his hands tend to be a little bit in a claw. They don't open fully because of the neuropathy. He has, I always notice it, but I think his face says a lot of what he was going through. He was unable to stand up due to a big foot drop and impairments in balance. That sitting position was his top motor skills. He wasn't able to do much more. So we had to start with muscle activation. We started with cardio training. We used a small bike to train him. We started with him tolerating training balance while he was sitting, reaching for things. We trained his balance while sitting. Afterwards, we were able for him to stand up. And of course, we tried to, we went for training of the gait. He was able to start walking with a walker, which is the second photo. And I think you also can notice that his face starts changing. We had a big emotional impact on the rehabilitation team had a big emotional impact on him. He was told that he was not going to be able to walk for at least 3 years. So then we start walking with this walker. We train for long distance. He was able to walk without it. And you can see in the third photo, he's able to stand on his own. And in the photo from the bottom left, you can see that, well, after we finished, he was able to walk on his own. He was able to be independent. Turns out he wanted to go back to playing football, soccer. So we had to train him to play soccer, which is also good for the balance training. And you can see that he was able to climb a wall. And he was discharged from physiotherapy rehabilitation during the pandemic. He was in for about 3 years in rehabilitation because he kept changing what he wanted to do. So we were aiming for him to return to football training, but the pandemic struck, so he wasn't able to do that. But I mean, he changed completely in the emotional aspect and the physical aspect, and it was all because we were able to do this as physiotherapy and as a rehabilitation team. Next slide, Abu. We also wanted to include palliative care because when a child gets diagnosed with cancer and they're referred to palliative care, we physiotherapists, at least in my experience and Abu's experience, we keep on seeing the patient. We don't change teams in palliative care. So our main objective as palliative care physiotherapists are to keep on to keep maintaining the quality of life of the patient, even through the process, to be a support system for the family, especially when they're quite impact after this diagnosis and after this referral team. And we try to keep him or her with her social role, which means that the child may be able to play until he dies, may be able to participate with his family, may be able to sit at the table while everybody eats. It's something that we have to keep in mind when the patient is in palliative care. Next slide, Abu. So here we change a little bit what we do as physiotherapists. Well, we still have pain. Pain is, we still have to be watchful of pain. It's something that happens a lot in palliative care, in pediatric oncology patients. And well, palliative care means that the patient shouldn't be in pain in this stage. We have to be watchful of muscle shortenings. We have to keep changing positions of the patient. We have to accompany both the child and the family. And we have to educate the patient and the family of what's going to come and how to be prepared for that. Next slide, Abu.
Thank you, Pia. It's my turn now. So grateful for Pia there sharing childhood rehabilitation and children's cancer. I'm gonna now just tell you a little bit more about a global perspective. So I wanna start by just acknowledging my position of privilege. I am from the United Kingdom. I'm very lucky to work in settings that are high income settings. And one of the things that I've had to understand or explore is that for many of us, that's not the same reality. So across the world, with healthcare in general and the provision of cancer services, there is not equality. So I very much talk from my perspective, which is the perspective of someone working in a high income country. But I want to acknowledge straight from the beginning that is very different around the world, and our experiences within this setting, in this room, are very different. So I want to quickly talk about income classification. So I'm sure you're aware that many organizations such as the World Health Organization use income classifications to describe economies, and they are classified according to the World Bank. So we have 4 categories. High income countries, the examples of these, for example, are the United Kingdom, the United States of America, Israel, South Korea, Australia. Then you have upper middle and lower middle, and then you have low income settings. So upper middle and lower middle examples include Brazil, India, Ghana, and many countries in Africa, and low income settings are countries such as Yemen or Haiti. So I'm going to talk first of all about perspectives, so different global perspectives in children's cancer. And then I'm going to go on to talk about global initiatives, so tell you a little bit about what's going on. And then the whole point really is to then tell you or us what is the significance, or why is this important for us physiotherapists and other rehabilitation professionals. So 18.1 million is the cases of global cancer each year. And this is children and adults. This is an overall number of people who have cancer each year across the world. And these are stats from 2018. And the WHO have a tool, it's a predictive tool, and it tells us that by 2040, so in little under 20 years, that incidence is going to increase by 50%. So we'll be nearly at 30 million cases of cancer globally by that time. So I want to just go back to children's cancer. It's a leading cause of death for children and adolescents worldwide. It's about the fifth main cause of death for children and teenagers. Unlike adults, and Pia alluded to the differences, that childhood cancer can't be prevented or screened. And the vast majority of children's cancers do not have a known cause. So very few cancers in children are caused by environmental or lifestyle factors. So we know in adult cancer that, for example, smoking and other lifestyle habits, diet, for example, play a big impact. Very few children's cancers are caused by these reasons. And we know that about 10% of all children with cancer have a genetic predisposition. So most children's cancers can be cured with generic medicines and other forms of treatment, like Pia mentioned earlier about surgery and radiotherapy. And treatment of childhood cancer can be cost effective in all income settings. So this is something that many of us, certainly within healthcare and even outside healthcare, aren't aware. There's this idea that actually children maybe can't be treated, and also that, you know, maybe it's prohibitively expensive to be able to treat children. And this isn't true. A lot of children's cancers can be treated, can be cured, and actually treatment can be very cost effective, even in all income settings. So the global incidence of children and teenagers diagnosed with cancer is 300,000. So every year, 300,000 children and adolescents are diagnosed with cancer. In high income settings, such as the United Kingdom, the United States of America, 80% of children will survive a diagnosis of cancer. So I'm very lucky, as I said, in the United Kingdom, we have an 83% survival. However, in low and middle income countries, the survival is 20%. There is a stark difference between the survival in high and low and middle income settings. In some low income settings, the survival is low as 10%. So there is a huge difference globally in survival of children and adolescents in high and low income settings. Added to that, the distribution is not equal. So 80% of the children who are diagnosed globally with children with cancer, they live in low and middle income countries. So the outcome for the majority of children who are diagnosed with cancer is extremely poor. Now, how that looks as an infographic here is at the top, you've got low and middle income countries. So this is sort of the blue color that you can see at the top here. And out of these, 80% of children who are diagnosed globally, only 20% will survive. Whereas in high income countries at the bottom, where only 20% of the global population is diagnosed, 80% of them will survive. So you can see there's a huge discrepancy. I want to move on to what is happening globally, and I want to introduce you to the WHO's Global Initiative for Childhood Cancer. In 2018, the WHO with partners launched this initiative, And the initiative provides leadership and technical assistance to support governments in building and sustaining high quality childhood cancer programs. And the goal by 2030, so in under 10 years' time, is to achieve 60% overall survival for children with cancer globally. And what that means is an approximate doubling of the cure rate and the saving of an additional 1 million children's lives over the next decade. For anybody that's interested, please have a look on the WHO's website and you'll see this is a global initiative for childhood cancer. Its objectives are to increase capacity for countries to deliver the best practices in childhood cancer care. And as you've seen from the slides I've shown, it isn't the same globally. We need to do more to improve that and to prioritise childhood cancer and increase funding at national and global levels. It just isn't a priority in some settings. This is a little infographic. I'm just going to take you through it. It's about this initiative. It was featured in Lancet Oncology. And what you can see here at the top, it says that 6.2 million deaths in childhood cancer could be prevented over the next 30 years. And it shows you here just at the top that, that there will be by 2050 13.7 million cases. But if no further investment is made, 11.1 million of these children will die. But if we put the right investment in, that number could be reduced to 4.9 million. And what we can see is that sadly 84%, so the majority of deaths will occur in low and middle income countries. And this is very interesting at the bottom. What this shows us, governments, unfortunately, because of economic reason, are unable to put this very small amount of cost in. But actually, what we see for that the productivity gains outweigh that. Actually, if we were able to put the infrastructure in, actually, we would get a lot back in productivity by these children surviving their diagnosis of cancer. So I'm going to move on now to the point here. What is the point of all this? What is the point of us telling you, us as physiotherapy professionals, about why this is important? So what we know is that global survival for children's cancer is improving through initiatives such as the WHO Health Organization Global Initiative. We should see more high quality children's cancer programs globally. And the goal is to improve survival to at least 60% by 2030. And that represents a doubling in the cure rate. And as I said, an additional 1 million lives saved. So we know that there will be more survivors of childhood cancer. So therefore, now is the time for us to speak up about children's cancer rehabilitation. Now is the time to raise the profile for children's cancer rehabilitation. Now is the time to start building networks and alliances. Now is the time to politically advocate. And now is the time to start, where it hasn't already, building and developing infrastructures for childhood cancer rehabilitation. And also, now is the time to start building the evidence where it doesn't exist to demonstrate the need for childhood cancer rehabilitation. So if we do this, what happens? So globally, we all have the potential to optimize the function, quality of life, and physical and psychosocial outcomes of millions of children. And this has the potential to have hugely positive impacts on the lives of millions of children, but also families. As Pia said earlier, this impacts not just the individual child, it impacts families and communities. We know that the burden on health resources for children who have disability through cancer is huge, and we can reduce that. And the socio-economic productivity. So by improving the quality of life, the function of many of these children, we're going to improve socio-economic productivity. And these are just a few things that we can achieve. So in summary, there are huge inequities in access to care and survival of children with cancer between low and high income settings. With improved care, the global burden of survivors is increasing and improving. An initiative such as WHO's Global Initiative will improve the standard of care and survival rates. But the time's now for us and other rehab professionals to start developing evidence, the advocacy, and the infrastructure to meet this imminent need. So I hope you can see this very lovely slide. I'm going to hand back to Pia, who is going to tell us about learning from her position in this beautiful city of Santiago in Chile.
Thank you. So we're going to talk a little bit of what was our experience during the pandemic. Here in Chile, the first cases of coronavirus happened in March 2020. And the immediate response of our government was to go on full lockdown. That meant that only essential workers, essential health workers were able to go to work. I work in an outpatient clinic, so we were not essential. And we needed to figure out a way on how to keep treating our patients. So we decided, of course, to go online, but we didn't know how. There was not a lot of knowledge at that time. And we started using Zoom to provide our patients with treatment. And we had to get very creative. We start using a lot of PowerPoint slides and PowerPoint ideas and games and things to keep our patient engaged in these online sessions. We actually saw a rise in adherence to treatment. On July 2019, we treated around 500 patients, and on July 2020, we treated more than 2,000 patients. We had a big rise in adherence. We were able to reach patients from different cities and different zones of the country. And what happened was that all the family got involved. We became like this break from the pandemic because we use different games, and we got involved, the parents and the brothers and the sisters, everyone got involved in the treatment because we were the only thing different happening during this pandemic. Next slide, Abu. But our main issue as physiotherapists, when you are used to what we call in Spanish that to putting your hands on the patient, and now we were unable to do that, we had to adapt. So a lot of the tests that I mentioned before, they were gone. For example, the 6-minute walk test implies that you need a 30 meters for the patient to walk on, and nobody has that in their house. So we had to adapt. We had to actually eliminate most of those tests during the pandemic. Here in Chile, we are still on lockdown. So we've been on different kind of lockdowns for more than a year. So it's not something that we have been able to resolve yet. And our assessment became a lot more subjective. We had to trust what the patient and the family told us. So, for example, for balance impairment, before we use some tests to objectify this, but now we have to ask the parents and the patient, do you feel that you have balance impairments? Yes, no. And the patient says no, then we have to believe him, even though you know that the patient has balance impairments. So that's something that became a little bit more subjective, and we have to protect the child of our sessions and to be more careful in them. If a patient, for example, if a patient has balance impairments, severe balance impairments, and I'm in this computer online session, I won't be able to ask him to do a lot of advanced balance training, because it may cause that the patient will fall, and I can do I can do anything through a screen to prevent that. So that's something that we became more careful. And one of the main issues we had, Chile is considered as a high income country, but we have noticed for the last 2 years that we are not a high income country. There are some people in our country that are, but not everyone. So one of the main issues we had was the internet connection. Almost 90% of our patients did not have internet access in their houses, in their homes. So they were unable to participate in these online sessions. And we, through some financial support, we were able to provide this patient with tablets and with internet access to keep on with their rehabilitation sessions. Next slide. And this is an example of what we had to do. You can see, well, this is Zoom, of course, and it's basically a PowerPoint slide with a Pokemon telling our patient that she has to be on one foot for 50 seconds. That's how we were able to survive this pandemic. Next slide, Abu. This is a video. And this is a video example of, Abu, you have to press the video. Yeah. So you can see that this is what I meant. This is another PowerPoint slide. It's all PowerPoint. We're very adept with PowerPoint. So we wanted the patient to jump over these pencils while we were playing this board game. And you can see, well, of course, he got distracted. He's like 4 years old, so he got very distracted during our session. But he was able to do this. What we want him to do, was to jump and to keep on doing his therapy. Next slide, Abu.
Thank you, Pia. So this is me now. I'm going to talk about some learning from London. I've had to put a sunset here because I can't compete with Santiago. There's no mountains in the background here. So this is a scene actually from my ward. This is my hospital out of the children's ward. This is the sunset we see. So this photo is taken from the children's ward. All right, so what I'm going to tell you about is a virtual training program for children's physiotherapists and occupational therapists. I'm sure for many of you that this was the same experience, that during the pandemic, all training was considered non-essential. So it was cancelled in most hospital settings in the United Kingdom. But through social distancing, we became familiar with virtual technology during the pandemic. And we used this experience and opportunity to develop a virtual children and young people's national cancer training program for physios and occupational therapists in the United Kingdom. So I'm sure it's the same with you. Local programs are very common. Each hospital and locality has training programs. We have never had a national training program in the United Kingdom. What we aim to do is bring together professionals from children and young people's principal treatment centres. So in the United Kingdom, that's the centres who diagnose and treat children and adolescents with cancer. We want to bring them together to share knowledge and training so we could enhance the care for children and young people with cancer. So the training programme runs monthly and it's delivered virtually to enable everybody to be able to access it. We've been running it for 9 months now, although it was disrupted for 3 months during the second wave of the pandemic. We started in August 2020, which was sort of shortly after the first wave. We had to pause it very unfortunately during the second one. And we've got 20 centres across the United Kingdom in attendance. And we have 100 attendees, so that's 100 different physiotherapists and occupational therapists who are attendees. And the average attendance for each session is around 40. So we think we're very happy with that. We think it's quite a good attendance. This just shows you some of the centres. So we've got many in London. UCLH at the top here this is where I work, and we've got other centres such as Great Ormond Street, which I'm sure you've all heard of within London. And then we've got centres in Glasgow and Edinburgh, so in Scotland. We've also got Belfast, which is Ireland, and we've got Cardiff in Wales. So it's all of the United Kingdom, and we've got many of the major cities such as Nottingham and Leeds and Manchester who attend our training program. But really positively is that out of the 19 primary treatment centres in the United Kingdom, we've got 16 at the moment who are engaged with this program. So we're very pleased about having the majority of principal treatment centres involved. This is a little map and it shows you the United Kingdom, and you can see that these are the centres that are attending, and as mentioned, we've got Scotland, Ireland, Wales, Northern Ireland and Wales all attending, and then many centres up and down the United Kingdom, including 6 within London who attend this training programme. And just to give you an idea of the topics that we've talked about, and these are all specific to children and young people's cancer, late effects, which is something that Pia talked about, radiotherapy, body image, exercise, physical activity. We talked about CAR T-cell, which is a type of therapy, brain tumor survivorship, and sarcoma. So this is just some examples of some of the topics that we covered as part of our program. Interestingly, we've actually submitted an abstract to SIOP, which is the International Society of Pediatric Oncology, because we believe that we're one of the first national programs. So we've submitted an abstract to the Congress, which is later in this year. So just a summary for you is that we are all now familiar with virtual technology. I definitely have to admit we were very behind in the United Kingdom. We used to always sit in a room or travel up the country for 5 hours to meet face to face, but now we are having to use virtual technology. It means that it's very easy for us to be able to create national programs, and like this, global training programs is very achievable. And apart from enhancing learning, it's got the ability to bring people together to enhance collaboration and networking and improve care of patients with cancer. And I think the model that we've used, it can be easily replicated. You could do that in your settings, and it doesn't need to be children's cancer. In any healthcare setting, you can easily reproduce this model and be delivering national and regional training programs. I think we've come to the end there, if I'm right. There's some references, so you can share these at a later stage. And I know we've got some, from when we started, we've got some new people that have joined. So good afternoon, good morning, good day to you all. Thank you very much for joining us. Thank you for listening. We hope that you have learned something. We hope that you found this interesting. We're very, very pleased, and thank you for the opportunity to be able to come on and share our experience and raise the profile of physiotherapy, rehabilitation, and children's cancer. And now there's an opportunity for you also, any questions, comments. We're very pleased to hear from you. So thank you.
Thank you so much, Abu. Thank you, Pia. This was wonderful. I really appreciated how you presented this from a comprehensive manner. You also had case studies. You've included issues related to COVID, the reality of the world right now. And then you showed how, how to address countries with low resources. Pia, your slides were amazing about how you manage these sweet children. And Abu, the structure that you've created is just amazing. And we can get this out globally and do some wonderful work. So anything our subgroup can do to support that will be, we're here for you all. For people that are here, I just want you to know that Abu is also our new lead for the special interest group in pediatrics. So if people would like to join the special interest group, we're hoping to have networking sessions, later in the year. Maybe just put your information in the chat. And does that make sense? Okay. And then or else, Abu, if you have your email address, maybe you could put that in the chat and people can also address you equally. I don't want to take a lot of time up, but I'd like to offer up, if anyone has any questions, if you could raise your hand and then Anne could call on you and you could speak on your microphone, or you can also ask questions in the chat because this was such an amazing presentation.
Pia, I would like to ask a question if I could. Hi. So we at our hospital also switched to virtual care during the pandemic. Well, we did a hybrid. We were able to see them in person as well, but I was intrigued by the great increase in adherence you had. And I'm wondering what factors you think all related to that, because my hospital is actually talking about how we continue virtual care or not. So I just wanted to hear more about that.
Yeah, so first of all, we had this rise in adherence. We were able to reach more patients in Chile, everything is far. We are located in the capital of Santiago, and a lot of our patients that we got referred were from other cities and other zones of Santiago, and it usually took them an hour to go to therapy, which meant they actually didn't go to therapy before this pandemic. But with these virtual settings, they were able to participate more. We had patients that were from 8 hours of Santiago, and they were able to join in this therapy program. So we were first able to reach more patients that before the pandemic were unable to go to therapy. And we also, as I mentioned, word got out that we were still doing therapy online, and a lot of, I mean, I had a patient that I saw him like 5 years ago and then never came back to therapy. And now with the pandemic, he decided that he wanted to continue therapy. And I was like, okay. And it's because we became like this break from the pandemic. We became this thing that, as you saw, we did a lot of board games. A lot of sister and brothers got involved in this, and they were like, yes, finally. And we also had a side effect that was not that positive, which is that most of our patients used to get like 3 sessions a week. And we had so many patients that we were unable to provide that. We had to provide like 1 session every week because we had to regulate how much we saw our patients because we had too many patients. Well, that was also positive because right now they were able to hire another physiotherapy and another occupational therapist. So I think that's like the main issue. Word got out that we were still doing this, and it wasn't therapy for them. It was like playing a game and being and having this break from the pandemic.
Is there anyone else that would like to ask a question? That was a great question, Lynn. You know, one thing, Pia, your slides were fun. I mean, they really were play and engaging, and of course, you're right. At that age, the attention span is not always there. But I think a lot of kids are used to, in some of the countries, are used to working online. So, you know, they had a little bit of comfort with it and helped develop it. And it's like, you know, the IT devices are so addictive sometimes. So if you can get something that's engaging with them, it'll keep them on. I also loved how you said your center was able to give iPads or you know, Padlets to the parents and the kids. That must have been wonderful in really increasing your ability to reach these kids. And I think this is another way that we have to find global initiatives to provide that internet care. Anyone else? We do have a question in the chat room from Robayo, ID Robayo, and the palliative management in COVID times incorporated any strategy of telemonitoring in the death of these children. So did you do, I think I'm interpreting it that were you also working with palliative patients with you know, care?
Yep. Yeah, so we did palliative management during, of course, we kept treating every patient. One of the, we have a big range of palliative care patients. We have those that have been in palliative care for over 2 years, 3 years, and are still very functional. And we have those that deteriorate very quickly, and the process is quite fast. So yeah, depending on the patient, but we still did telerehabilitation. And when the patient was reaching this end of life stage, we kept a lot of contact with the parents. We use a lot of, we call the patients, and if it was an urgent case, we were able to go to visit them at their home before before they pass, or if they had they had some issue that needed resolving. For example, we went to see a patient that, according to the mother, had deteriorated quite fast. She didn't know how to put her in the wheelchair. So we went and we taught her how, and we got to spend a little bit of time with the patient before passing. And we also got that through technology right now. Even if the patient passed, we still keep reaching out for the parents. We had this more close connection with them due to, well, we use a lot of WhatsApp here. So we keep talking with them even though the child had passed. So we were able to strengthen that connection. It wasn't just them going to therapy and that's it. It was more than that.
Thank you, Pia. You know, I remember one thing that you said in your last presentation last year, that during COVID, you know, by doing the online training, it made the parents become advocates for the child. And so some of the therapy was better from that perspective, because it wasn't just the once or 3 times a week training. You actually had the parents knowing something and then being able to take on the responsibility and then, you know, enhance the rehab. Do you want to comment on that?
Yeah, so since we're an outpatient clinic, most of our sessions tend to be, the parents tends to stay in the waiting area, and the child goes with us for 2-3 sessions, and that's it. And you of course you always give feedback to the parents, but in this telerehabilitation mode, the parent had to be involved. I mean, if the patient, and we actually had a lot of cases of patients that start walking during the pandemic, or improve a lot in their functional levels, because the parents got involved in the sessions and they were able to replicate this every day, and they were able to participate, and they finally understood what had to be done for the child to improve. So it was something very positive on that. And even if the parent did not get involved, the siblings got involved, and everyone was able to replicate what we want them to do in their everyday life. So it was quite positive.
And Pia, you also talked about the teenagers. They became advocates for themselves, you know, the preteens and the teenagers. Do you want to talk about that a little bit?
Yes, I love teenagers. They're and I don't understand a lot of teenagers right now. They with their TikToks. Actually, TikTok became quite the tool to have them participate in rehabilitation. It was also what was this name called? Among Us. I don't know if you heard of that game, but
Oh yeah.
okay. So we started playing that game with our patients during our therapy sessions. So the one that lost had to do like a challenge, and had to do, for example, I don't know, 15 steps walking a line, and it became a tool for us. So yeah, a lot of teenagers, they got very involved in their therapy sessions. They were able to replicate this, and we created a small network of teenagers, of our patients. So they were encouraging each other to keep on working, to keep on doing their therapy. And I say therapy because it's not only physiotherapy that we provide as an outpatient clinic. They challenged themselves, and they were like, the teenagers became, they have their own minds. So they became like this big force that they will ask for, I'm sorry, I haven't had physiotherapy. Can I have my sessions this week, please? Can they be 2? Because I feel like I haven't done a lot, so I need more than 1. And they became their own advocacy. And this was even 10 years old. 10-year-old also became their own advocacy in this pandemic. They are very clear of what they want, and they wanted to participate in as much therapy as possible.
Wow, that's just amazing. And we know that even adults exercise, they adhere to exercise if they have a support group or they're working with others. So that's just amazing. You need to write that up.
Yes.
There's two questions right now. One, I'm going to let Pia have the next question, so it's along the same lines, and then there's one for Abu. In the chat box, Adi Robayo is asking, how can you describe some of your experiences with handling grief?
Oh, grief. Well, honestly, you learn to handle grief. I think as oncology, pediatric oncology, or anyone involved in oncology, you learn to handle grief. That what I've learned is that honestly, no, the only thing we all are sure of is that we're all going to die someday. Hopefully not today, of course, but we're all going to die. That's the only sure thing, that you can be from any part of the world and that it's going to be the same. And some people tend to die a little bit earlier. I'm very, not very, but I'm religious, so I tend to get a lot of support on that area. And as I mentioned, even when you have a patient that's in palliative care, you get to handle your grief earlier. You know the patient's going to die, so you make the most of what remains of his or her life. You become the support to the family. You try that to that day can also experience these final stages of life very involved, and try not to make this like a big depressing thing. You try to keep on living, that the child keeps on living, while still being present. And as I mentioned, you also even when the patient is gone, you still keep in contact with this family. So it's something that gives you a little bit of closure. And of course, you never forget a patient who has died. I'm very clear of all the patients that have died while I have worked in this area. So it's something that you learn to live with, and you learn to manage, and you get to do this long grief process when the patient goes into palliative care. And I always say that I think it's more devastating hearing when a patient goes into palliative care than when you hear that the patient has died, at least in my experience, because when he or she goes into palliative care, it's like, he's going to die. That's it. But when it happens, it's something that sometimes can be seen as a positive thing.
Thank you, Pia. Does anybody else have any comments on how they manage grief in this population that they'd like to share?
I can't. Oh, you go ahead. Oh, she popped on and popped out. I think a long time ago, a nurse told me that that you see it as an honor to know them, and in the short time that they're here, and that you can learn that they live this long life in a shortened time, and they're wise. So all these kids are so wise, and I feel like we see that as, if you really see it as an honor to get to know them over this short time and the family, I think that's how we deal with it.
Thank you, Lynn. Abu, did you want to comment on that?
Hello. Yeah, I completely agree with those same comments. And I think for us, what we do is this process of reframing. So we can look at the child and we see them as a child, or we can see the cancer. And we can't control the outcome, but we control how we view things. And if we choose to see that child and that family as a beautiful child and a beautiful family, and we choose to focus on the fact that they can smile, or they can walk, or they can play, then we are focusing on them rather than the cancer, even though we know it's there. And we can control our part of it, and the things that we can't control, we like as Pia said, that we can we just have to accept those for what they are. And for all of us working in this environment, we know that we're going to come across death and grief and dying, and trying to understand that, what is with our control and what can we influence, and what are the things that we, however, Pia's given an example through spirituality, but I've given an example through reframing, whatever tools that we have to try and understand the things we can't control. I always think of a video I saw. I think he's an American actor. He lives in the UK. His name's Rob Delaney, and I think that he had a child, if I remember, who died of a brain tumor. And he talked about love and grief being intertwined. And for me, that's always stuck with me, that we feel grief because something means a lot to us. And, we all value the role that we provide. We're all, as professionals, it means a lot to us, the work we do. And the more that it means, the more difficult it is for us when we lose that. So I think it's really important to recognize that sometimes that things they're so difficult for us because they mean so much to us. So it's that I think helps us to get through and helps us to do better and helps us want to do better for the next family and the next children that we work with.
Thank you, Abu. I just want to make a quick comment with a question. I have not worked with children in palliative care, but the adults, I have worked with adults in palliative care, and I tried to provide them obviously with rehabilitation, but one in particular, he was walking and exercising, and he ended up mostly using an exercise bicycle. And his wife told me that the bicycle gave him a way to control his disease. So he had something that he could control, with his pain medicine. He felt that the exercise made him so he wasn't taking these overwhelming medications that were making him sleep all the time and not be, present in the final days. Do you think that some of the activities that you give the kids give them some control over their life? Okay. Do you want to comment on that, or?
Yeah, I think I 100%. It's what Pia said. We take them out of their normality. We put them in a hospital. We put lines in them. We treat them. We give them drugs and treatments, which are unfortunately quite horrible. And giving them normality back is so important. So allowing them to play, allowing them to do activities and sport, do the things they really enjoy and like. You're 100% right. It gives them that control. They are not in control, and as I said, unfortunately, in terms of consent for children, they can't say I don't want the treatment. They can't. I mean, some can if they reach that age, but many, their parents consent, and it is the right thing to do, but it is not a good experience for them. So encouraging as much as possible them to be participating, continuing. There's no reason why they're having cancer treatment. They should still be accessing school. They should still be washing and dressing and eating by themselves if they can. They shouldn't be in hospital gowns. They should be in their own clothes. We should be encouraging all these things. And you're absolutely right. That is about allowing them and facilitating them to control and be part of the things they can. And those things are going to enhance their quality and their life, regardless of everything else that is going on in the background.
Thank you, Abu. There is one other question in the chat along this line from Paula Ahumada, and she wants to know, are you able to assess these patients online, in hospice? Like, what were some of the assessments you might do?
Yes, well, we have like this online assessment tool, and it's a little bit different for palliative care. It doesn't focus that much in the functional aspects like strength and balance and and all of that. It focuses a lot more on what the symptoms of these patients are during what symptoms they're experiencing, what's going on with them. We use the the different scales, and the ECOG, the Lansky, Karnofsky, Edmonton, and a lot of other names of symptom scales that we use. And we focus a lot more on pain, on what's their level of pain in the last 24 hours, what have they done to it. We have a very close relationship, since we're an outpatient clinic. We have a close relationship with all the palliative care teams in the different hospitals that we receive patients from. And we tend to see much more, we tend to give a much more close relationship with the patient and the parents. So we are the ones that have to tell, that have to advocacy for these patients in the hospital. Like, he keeps telling me he's in pain, the medication hasn't worked, is there anything else that you think you can do? And this assessment is like the same, just we focus a lot more on symptoms than on functional levels.
Okay, thank you. I'm gonna change gears a little bit here because there's another question out there that for Abu, and it's from Marianne Dalzell from Canada, and she's asking, did you have any funding for your national training initiatives? And could you describe like where it came from and where it went and how it was managed?
I'll let you guess. No. Unfortunately, and I'm sure you all have this experience, so much of what we do in healthcare, and I would say so much in cancer and pediatrics, is all about goodwill. It's all about like-minded people coming together. Unfortunately, no funding. It's something we're going to look at, but what we did is we utilized social media, we utilized networks, and we got people together, we got people talking and said, look, this is a wonderful opportunity. What do you think? And we've got a group of people together to organize it. But unfortunately, and many of you will experience this is stuff that we had to do maybe in our own time, because the resource doesn't necessarily exist at work, and certainly, unfortunately, we didn't get any funding. So we're utilizing free platforms like we actually use Microsoft Teams, and the training is kind of training that we would all be doing on our own. So we just opened it up to allow other people to attend. But that's just the start. So we're now working with United Kingdom's professional body, which is called the Children's Cancer and Leukemia Group. And we're going to see if they will endorse our program. So they may do that. We haven't started that process yet. And to make it bigger, to make it better, we would have to get funding. So there's only a certain level that we'll be able to achieve if we continue the way we are. In future, hopefully, we can look at that funding, and that will allow us to do better things. But it's 9 months in and disrupted by a pandemic. So at the moment, this is I would say, a voluntary effort from everybody. Jackie, you're muted.
Thank you. There's a question from Eric Galvez from the USA. Is there any funding from nonprofit organizations?
So again, I think so, and I hope so, that's a possibility. We just haven't started looking into that. I think the next step for us, I didn't mention it, is that every session is evaluated. So we send an online survey, and participants can evaluate the sessions. So I think what we plan to do is evaluate maybe after a year, see how well we did, how many participants, and also the feedback. And then I think we'll have to present that to professional bodies and non-profit organizations to see if they would be interested. So it's the start, and maybe that's something we could come back and tell you about in future. I don't know where we're going to go with it. We're very pleased so far, but grateful for these ideas about people that we can approach. Because as you all know, there's only so much you can do out of goodwill and in your own time. To make things really work, you have to have some finance and some backing behind it. So it's certainly something in time we would be looking at trying to achieve. Thank you.
Yeah, thank you very much. And I think you getting the word out and making people aware of the conditions globally, you know, that knowledge or advertising typically in the end will help, but we just have to keep getting our message out there. I just want people to know that we will post this video to our YouTube channel within the IPT-HOPE website. And do you want to put the website up in the chat room? And then if you're a person from one of our member organizations, if you'd like to post your name in the chat line, we can provide it to Abu, and you can become a part of the networking session. Again, we're a rather new subgroup, but we're planning to have some networking sessions throughout the year, you know, for each of our special interest groups, which is pediatrics, oncology, HIV/AIDS, hospice and palliative care, and then lymphedema. So we're going to be moving in those directions to get the word out and get people joined up in our networking sessions. So we have our own support groups here. Does anyone have any final comments that they'd like to make? No. Okay. Anne, did you have a comment? Go ahead, Anne.
Yeah, thank you everybody for attending. I think, Abu, you kind of addressed this, but I was wondering how to bridge the gap between countries that can provide care to children with pediatric cancer type diagnoses and those countries that are less fortunate. How can we bridge that gap? Is that sort of where you're going with that program? Thank you.
Yes, it is, and thank you. That's such an important question. And in the time I had, I was sort of giving you a flavour. There's so much more to say, but really, my and Pia's reflections are that globally there are quite good links between resource limited settings or low income settings within the field of doctors and nurses. So they have established some very strong programs globally. But like we see at local levels, allied health professionals, physiotherapists, occupational therapists, we're a much smaller group. So those links are very new and they're very small. So certainly my view as an SIG lead and some of the work that I'm doing outside of this with Pia is that the first step is trying to create networks. So it's getting people talking and getting the knowledge shared. What we tend to do, unfortunately, is at a national level is we do stuff in bubbles, so we don't share that information, or it's shared in ways, for example, through journal articles, which they're not that accessible to everybody out there. We take for granted, for example, accessibility, and Pia talked about it, about internet access. Not everybody has that. It is getting better, but the first step is really about creating networks so that people can start talking, we can start sharing knowledge, start sharing best practice. But we would describe children's physiotherapists who work in cancer were described as unicorns by one of my doctor colleagues, and I think that's a really good analogy that, you know, there's very few of us, and we know that in some settings, in low income settings, there are no children's physiotherapists and there are no children's cancer physiotherapists. It doesn't exist because they don't have the resource. So we have to acknowledge that in order to bridge that gap, we have to pull the resources together. We have to pull us, and in time, hopefully, that's the first step. There's many, many steps along the way, but that's the first step to bridging that gap and advocating for change.
All right, thank you. This was just an excellent, excellent presentation. It's done so much good, you know, to get this information out, and this is actually a part of a networking session. As I said before, this will be posted to our YouTube video channel within, you know, our website that Anne posted on the chat line, or you can just type in IPT-HOPE and it should take you to our website. Abu and Pia, you will be getting an International Scholar Award from Nena Chegbo, who's our educational lead and our executive board member, and she's also the president of the Nigerian Physiotherapy Association. So excellent work, and, you know, any way that we can support you in this, you know, we're just more than happy to do that. So thank you again.